Okay, recording started.
Thank you. So I'll just give a quick recap. The recap for yesterday was a comprehensive study that we mentioned, and it was mentioned that to do a comprehensive examination of an echo, you need to understand the windows. And we mentioned that there are 5 windows in which an examination of the heart can be viewed. We have the parasternal long axis, we have the apical four-chamber, we have the subcostal, we have the right parasternal long axis and the suprasternum. And I also mentioned that each window that we have, it has got specific structures that you can see on echo. I also mentioned about the patient positioning. Typically, a patient is positioned in the left lateral decubitus with the hand raised and the head is above the head. The reason is very simple. We want to see and spread the intercostal spaces. Not only that, I mentioned that the cardiac probe, a typical cardiac probe, has got a very small footprint so that it can go through the intercostal spaces. And when you position your head, your patient in the left lateral decubitus, all you want is you want to push the heart so that it's closer to the chest wall, the anterior chest wall. So such a position is very important to take note. I also mentioned that sometimes you may have a patient who cannot do that technique. You can let the patient be in supine and go ahead with your positioning. Always examine your patient on the right side of the patient and adjust your equipment, your table up to a level where you can nicely pick you can place your cardiac probe. We even explained further to say these windows, you must also know in which view where you are orienting it. It was also mentioned that the cardiac views, they are inverted. It's not the way we see images in ultrasound, general ultrasound, because you see the inversion of the heart. Particularly, you are going to have the left ventricles on top, and then you are going to have the right ventricle, the atriums just below. And we explained why they appear the way they appear. We went further to discuss structures that are seen, for example, in long parasternal axis. Why do we call it a long parasternal axis? Because the heart is in longitudinal section and we are just adjacent to the sternum. The following structures could be seen. We mentioned that you can see the aortic root in long parasternal axis. You can see the left atrium. You can see the mitral valve, both the anterior mitral valve and the posterior mitral valve, the cordial tendini, and the papillary muscles. You also appreciate the LVOT, or the left ventricular outflow tract. You're also going to see the left ventricle. You're also going to appreciate the right ventricle. You're also going to see the septum. More importantly, you're also going to see the descending aorta. So these things can be seen. And I also emphasize to say this is one of the most important view that should be always given attention and taken properly. Make sure you optimize the chambers of this view, because this is the view where you have to calculate your ejection fraction. And remember, ejection fraction is one of the most important systolic parameter or component that is needed by a clinician. Why? It gives you the function aspect of the heart, the systolic function of the heart. So once you mess up with this view, you are likely to do and make wrong diagnosis. And I also mentioned that these parameters in echoes, they are very, very small figures. So any mistake of a poor technique, you are likely to give wrong diagnosis. We further discussed about short parasternal axis, as in cutting the heart into different planes. I gave a schematic diagram where I said, assume that like you are seeing the heart from the top, where you can see the aortic valve you cut your aortic valve level, short parasternal access, you go to the mitral valve level until you go to the papillary muscles, and the last one as the apical view. What was the importance of that? I think I mentioned each view has got its importance, why we have to do that. I actually explained further that the view, the short parasternal access at the mitral valve level is very, very important to quantify conditions of myocardial diseases or myocardial infarctions, sorry, myocardial infarctions. Why? This is where you can appreciate the 5 motions of the heart. I think I never mentioned the heart can make, it actually makes 4 motions or rotations that goes on within there. One of them, it's the longitudinal. I'll explain that with the head of a diagram. The longitudinal section, the heart can be going to the longitudinal section. It can also make circumferential motion. It can also make the radial motions. It can also make the combination, the circular motions. So when you look at the heart when it's in motion in real time, you find that it will be twisting. At the same time, it will be contracting inwards and outwards. And at the same time, the muscles will also be going circular. So when you look at it, it will be rotating, making circumferential movement. Those movements are very important. Why are they important? They are very important because they will help you to know the normal cardiac motion. And this is how you can say the segment of this part is abnormal, there is poor motion, and you see people start bringing issues like, no, there is hypokinetic, hyperkinetic, there is dysynchrony, there is akinesia. All those things, they will come in because you have to understand the motions of the heart. And some people, they will also comment on things like normal wall motion, normal global wall motion. So it's because they're able to assess, they're able to see what's going on there. The other thing that we talked about was the application. We also discussed the apical 4 chamber. This apical 4 chamber is very important. You have to understand, know exactly where to do your sample gate, how to apply the pulsed wave, how to apply the continuous wave, and where exactly do you put the sample gate. And then we also went further to explain even issues of the color Doppler. I stressed how you should interpret, understand the color Doppler, why it appears red, why it appears blue. I mentioned that we've got the color code. That color code that we have is divided. It's coded red above and blue below. When you see the red above, that is a positive shift. It's indicating the positive shift. And then below you've got the blue, which is the negative shift. I mentioned to say that has got nothing to do with oxygenated or deoxygenated blood, but it has everything to do with the flow of blood. Is it moving positive towards the probe or away from the probe? Again, we concluded to say all these modalities, they've got their implications. I demonstrated the M mode, how you can tell the M mode on the mitral valve level, on the papillary muscle. I explained what the EPSS is. And then we concluded further to say these modalities can also be applied at different levels. Things like the aortic arc. We explained that the aortic arc can only be acquired using the suprasternal view, where you put your probe on the sternal notch. You are going to appreciate the branches of the arc, which is the brachiocephalic, the left common carotid artery, and the left subclavian artery, the 3 branches of the aortic arc. What is the importance of that view? It's very important to check issues of coarctation, aortic coarctation. What is aortic coarctation? Aortic coarctation, this is the narrowing of the aortic, ascending, descending, and ascending aorta. It can narrow. This can be a congenital anomaly or it can be acquired, but coarctation can be well appreciated. And then we also said this can also be very useful in terms of aneurysm, aortic aneurysms, and then things like aortic dissection. So all those things, we explain them, they can be seen using that. And then further we said this color Doppler that we are using, it can be very useful to quantify specific diseases that you may experience. So having said that, I'll open the discussion so that we can discuss in a very typical way. We give the tips and then clarify some few things that are there so that we can clear some doubts and some things and anything that you want me to clarify pertaining to yesterday's lecture. The idea is to digest it so that we polish it and we move. Remember, I mentioned that today's lecture was supposed to be parasternal long axis and the spectral Doppler. So I would be very happy if people can ask questions, clarify, at least each from everyone. We can discuss it deeper. And then I talk about the spectral Doppler. So that was the summary for yesterday. So I'll start with the, okay, anyone can start, but at least give a question or anything that you want to clarify for yesterday. That's the reason for this open discussion. Thank you. And we want people to participate, how they, so we can start.
Okay, Mr. Mulenga, my question is not on yesterday's lecture, but the first lecture that we had.
Okay.
Yes. Could you clarify when do we apply pulsed wave and continuous wave? Are there specific conditions or yes, something like that, when you can apply pulsed wave or continuous?
So, okay, thank you so much. So I'll be picking 2 questions per session. So I'll write down that one. Next question. Anything next thing that I can discuss as a set of questions?
Mr. Mulenga.
Yes, madam.
I would just like you to explain more on the right and left ventricular outflow tracts and their importance and their significance.
Okay, right ventricular outflow tract and the LVOT.
Yes.
Okay, thank you. So I think I've got 2 questions. So the first one, it's about, do we have specific conditions where you apply the pulsed wave and the continuous wave? The answer is yes, but I'll explain it this way. I think answers are already there. So before you apply your continuous wave, you must understand what it does. And by doing that, you are not cramming. You want to understand what it is. It's because you are going to justify why you are using it. Even when you are in an exam, you are going to say, I'm using this because I'm suspecting this, I'm doing this, I'm doing that. So first thing first, pulsed wave measures normal velocities. And the fact that pulsed wave measures normal velocities, you must know when to use it. For example, if I'm doing a normal echo, just a routine echo, not really a normal echo, and then I want to see the flow of blood across the mitral valve or across the aortic valve or across the tricuspid valve, just a normal flow. Or even I want to see the flow passing through the aorta. I'm going to put my sample gate for pulsed wave on a specific spot For example, if I want to measure the mitral valve, I want to know the velocities that is passing there. Remember, pulsed wave and continuous wave, these are Doppler modalities. All they do is to measure velocities. Don't think of other things. They do measure velocities. So pulsed wave is going to measure low velocities on a specific point. And naturally, the cardiovascular system has got low velocities in the body. Whichever velocity you are going to pick, normally within the body, we've got low velocities. That's why we get concerned when you are having high velocities on any area. I remember very well during my first lecture, I said the cardiovascular system is a closed circuit. So anything that will tamper with the normal velocities of the blood, including hypertension, we get worried. So we are using pulsed wave for normal velocities, and we can only switch on to continuous wave when we see that this pulsed wave is failing to pick the correct things. So to cut the story short, pulsed wave, like you know, it measures low velocities. It cannot quantify regurgitation, because regurgitation, it's an abnormality that can come due to stenosis, that can come due to an abnormality, either physiological or mechanical. So we use pulsed wave for normal flow, and we use continuous wave for abnormalities. The three abnormalities where you use continuous wave: one, you can use continuous wave for stenosis. Why are you using continuous wave? Because it measures a wide range of velocities. It is non-specific, and it also measures higher velocities. Conditions I've already mentioned: stenosis, regurgitation, and in shunts. A shunt, you can have congenital abnormalities that can give you shunts. For example, you've got a VSD or an ASD. So when we talk about the shunt, we are simply saying sometimes blood can be shunted. By shunting, I mean blood is being directed to one direction instead of going to the normal direction. So when you have an ASD, which is a defect between the two atrium, there is a hole. Normally, the pressure on the left side of the heart is high than on the right. So we are going to have the left to right shunt. So velocities, the velocities from the left, they will be transmitted to the right. There will be more. So across the shunt there, you can quantify after you see there is a VSD or an ASD. You put if you see there is a VSD, don't even waste time to start putting a pulsed wave, because that is an abnormality. The pressures there, they are very high. Put your continuous wave so that you measure this high velocity so that we know how much pressure is being transmitted on the other side. And when we talk about pressure within the chambers, they should be maintained at a certain threshold. Once they become abnormal, they can affect other structures. These discussions, will have them on individual diseases as we go ahead. But for now, continuous wave, you use it for specific conditions. You don't just use continuous wave anyhow. You apply it for specific conditions. I hope I've tried to explain it. What is RVOT and what is the LVOT and their clinical significance? I think that was your question. Is it?
Yes.
Okay. Anatomy comes in. RVOT, it's when you picture the heart, you've got the left atrium, the right atrium, and the two ventricles. So when blood moves I'll start from the right. When blood moves from the right atrium, it has to come into the right ventricle via the tricuspid valve. From there, right ventricle, blood must move through the right ventricle outflow tract, and it goes into the pulmonic valve. So the relevance of the RVOT is that sometimes the RVOT or that tract can be obstructed in cases of tetralogy. It can be obstructed, congenital obstruction, or sometimes the RVOT, the same one, there can be a lesion there. So it will obstruct the flow of blood going to the pulmonic circulation. What is the implication? The implication that you'll be having poor oxygenation. The other implication is that there will be venous return. So blood will be coming back now to the right ventricle, and there will be fluid volume or fluid overload. So understanding the RVOT is very important because it can be obstructed and it can cause other conditions to respond to that. So once you realize that, oh, there is a defect or there is a condition that may be affecting this, you have to check it. What is going on in the RVOT using the right parasternal long axis. That's how you check it. You don't see it in the left parasternal long axis. You see it on the right. You also see the left parasternal long axis. You are going to appreciate the LVOT. What is the clinical relevance? The clinical relevance is that you are going to appreciate the regurgitation. Most of the aortic regurgitation occurs, you actually appreciate it in the LVOT. And then at the same time, sometimes the LVOT can also be obstructed by hypertrophy. When there is an LVH, you are going to have that obstruction. It will obstruct the LVH, and the LVOT, it is also referred to as a chamber. It's called also a chamber. Why is it called a chamber? Because it can also help you to appreciate what is happening within the aortic root, and if there's any regurgitation, and then it will also help you to see the flow that is happening within the aortic root. So the clinical relevance is basically to see, is it obstructed? Sometimes you can have what we call LV hypertrophic obstructive cardiomyopathy. Hypertrophic obstructive cardiomyopathy, which they can call HOCM. Okay, now what is this thing? You can have, let me just show you something. I'm trying to load this. Okay, so you can have, are you able to see my screen?
Nothing yet.
Okay, but you can have obstructed LVOT. I think those are the two clinical significance. And the danger is if you have an obstructed the LVOT, patient may present with syncope, or a patient who comes with history of, you are going to be having patient who comes with history of syncope. They want an echo. You start wondering, echo, syncope, somebody faints, they want an echo. What is it? They want you to see the LVOT. The question is, what is the pathophysiology of fainting? It's poor perfusion to the brain. And who perfused the brain? It's the heart. So what else can you check? Are we having the proper flow of blood from the aorta? And don't get surprised if you find that things are okay. At least you've answered the question. The LVOT is open, the aortic valve is patent, the patient is able to receive. And you can even go further if you want. Check the aortic arc, are we having the blood supply properly going to the brain? Those are the things. Mr. Msonda, you can make me the host so that I can share. Sorry, I can just share the screen. So you find that all those things, you must integrate them so that you understand what's going on. I hope I've tried to answer those questions. The next questions?
Yes, I have a question.
Yes.
The question is on in diastole.
Okay.
The AML movement.
Mr. Mamba, I'm the host now.
Hello?
Hello? Is Mr. Mamba there?
Me?
So just a minute, I wanted to share something. Mr. Mamba, am I the host? Because I can't claim the host. Okay, maybe it's off. Okay, you can go ahead. It's okay. I'm sure it will appear. You can go ahead. Sorry. Hello?
Hello?
You can go ahead. I'm getting you.
Yes. If it's possible, I don't know if it's possible if we can share that diagram again, the one that you were exhausting on the EPSS, the endpoint to septal separation. Yes.
Okay, I'm trying to share, but I think I think it's now coming.
Mulenga, you can share now. Sorry, I was struggling with the controls.
Okay.
No problem. I said, I was waiting, so I quickly had to come to the. All right.
No problem.
Okay, you can see your screen now.
Thank you. Okay, the EPSS.
Yes, the endpoint to septal separation.
This one.
In relation to ejection fraction, yes.
Okay, nice.
When we're exhausting on the M shape.
Yes.
The D for the leaflet opening, P
yes.
for peak opening. Is it A for arterial peak or arterial emptying?
Yes.
So I would just appreciate if you can maybe just go through it again.
Okay.
Yes.
Okay. I'll start from here. I will come back to this, no problem. So when you look at this scan line, this line which is there, it's
Are you
passing.
taking a second question, Mr. Mulenga?
Yes, I've already taken it. I can still repeat because there's nothing much about the LVOT and the RVOT.
Oh, okay. No, I thought you said you'd be taking two questions at a time. I don't know whether two questions have already been asked.
Oh, sorry. This is the second one. The next question. Sorry. Next question. I can take the next question.
Okay, so maybe I can ask the second question.
Yes, sir.
I just want clarity on Bernoulli's principle. And
yes.
When I was going through the slides, there's a point where I saw where it was talking about the stenosis, where it says
yes.
fast moving blood flow such as stenosis will retain high velocities. I thought it's at variance with what Bernoulli's principle was saying. Maybe it's just me confusing myself. I don't know. I would want more clarity because from what the Bernoulli's principle explained,
yes.
I expected it to be the other way around, as opposed to what is in the notes.
Okay. So what was your analysis? We can pick it from there. Your analysis, you were thinking?
I was thinking that according to Bernoulli's principle,
yes.
where you said at a point along a horizontal streamline, I think that should be, there's on slide 21 and something before that. If you can just, I feel it's at variance with each other.
Okay. So
I don't know if it's just people didn't understand properly.
Okay, I get you. So we'll start with this question and then we'll come to that one. So when you look at this line which is there, that is the scan line. whatever is here, it's been depicted there. So it's passing through this line, this structure here. It's the LVOT. Sorry, this structure I'm seeing here, where I'm pointing, that is the septum, and it's already marked as a septum. This is the RVOT, and then this is aortic root. And then these two bulging, I think there are these two, this bulging and that bulging, and then in between there's that line, like that line, that is a closure line. It means the aortic root is closed. And then when you come here, you see the anterior mitral valve leaflet where it's pointing mitral valve. It's a leaflet, that one. Then we've got the posterior mitral valve leaflet, this one, which is here. And then you've got the descending aorta. Now, you must understand always that which view is this. Once you orient yourself with the view, then you are comfortable to go ahead and start these things. And sooner or later, you won't even be questioning which view is this, because you know what you are doing. Now, once you pick this one, I want you to notice that there is a distance between the anterior mitral valve, this one, and the septum, that and this. Now, what happens in diastole? In diastole, when the mitral valves are widely open, these valves, when they are widely open, remember there are four phases. There is early diastole, end diastole, end systole, and late systole. So there are times when it's in full rapid filling, which is this one. Okay, so D, for example, at D, here, the mitral valve will start opening slowly. Slowly, they will start opening. And when they reach E, it's peak opening. That's why they have written peak opening, and there is rapid filling. And it's at E where the EPSS has to apply and understood. So at E, this anterior mitral valve, when there is this peak opening, okay, when there is peak opening, the anterior, sorry, the anterior mitral valve, it has to touch the septum. It has to touch the septum. Now, touching the septum simply shows you indirectly that the left ventricle is receiving the expected volume of blood, because they have widely and openly opened, and it has filled, because these valves, they can open wide. And it is represented by this, it's touching there. You've seen the anterior mitral valve leaflet track. So this is the contact that I'm talking about. This is the contact. This is the contact. There's a contact there, the contact there, the contact to the septum. This is good. Now we measure the distance from there, that small space which is there. We measure it. We measure that space from there to there. We normally measure it in a vertical way. You measure it from there to there. The distance from that space between the septum and the E point, it is called the end point to septal separation, the EPSS. The lesser the EPSS, the greater the ejection fraction, indirect. So for me, when I'm doing an echo, I'll do this EPSS, and I'll even know that, okay, I'm dealing with the normal ejection fraction. I don't expect to get an EPSS, which is maybe, for argument's sake, maybe 16 millimeters or 1.6 centimeters. And then I come and find the ejection fraction, maybe 70 or 60. Then there must be something wrong. But you measure that EPSS. So normal mitral valve must open and attach the septum. What does it mean? It simply means the LV is filling properly. That is very important. And then you also have to understand that when the EPSS is big, now what makes it big? Now in diastole, we said it has to touch there. But the moment you are going to have the left ventricle dilatation, when the LV dilates, normal LV internal diameter, maximum, it should be 5.6 centimeters internal diameter in diastole. In diastole. Why am I emphasizing in diastole? It's because when the heart is in systole, it contracts this muscle, the septum here. The septum and the left ventricular posterior wall, they thicken, just like the biceps. When you contract, the biceps thickens. So they reduce the cavity. Maybe if it was like that, it will thicken a little bit like this, up to somewhere there. So once the LV dilates, it widens, it dilates, widens. The EPSS, it won't touch to the septum. It will be far. This thing will be far because it has dilated. It will be far. So you are going to have a big gap in the EPSS. And when you measure the gap, you won't see this gap, this touching. This septum will be pushed up because of the chamber. This is a chamber from here to there. This black thing that you are seeing here, the whole lot of this, it's a chamber. The left ventricle from there to there, it will dilate. And once it dilates, it pushes there, and the EPSS will be increased. And the only condition that can dilate this, or when the left ventricle is dilated, we call that as DCM, dilated cardiomyopathy. So in dilated cardiomyopathy, one of the things that you look at is that there is low ejection fraction. The EPSS is high. The ejection fraction is low, as evidenced by what? One, the end to septal separation point is long. That's why I said, don't conclude an echo on one image, please. So EPS is just one of the parameter, an indirect parameter to measure ejection fraction. And when you see the EPSS is big, it doesn't mean you won't calculate the ejection fraction. Do it so that you can have the actual value. You can quantify your ejection fraction, even when you know that the ejection fraction will be low. Normal EPSS literature says 7 to 8 millimeters. Others, they even start at 5 to 8 millimeters. Anything above the EPSS has increased. I don't know, have I left any other part to mention on this? Hello? Hello, hello?
Yeah, no, and no, I'm following closely.
Okay, have I left any part? Or I go through all the letters here?
Yes.
Okay, do you understand now the D part, the D? You understand the D?
Yeah, I do.
Okay, so the AML and the PML, the anterior mitral valve leaflet, this AL, it's this one here. Or, in fact, it's written, this is the one here. Okay, this is the one here. And then which one can we pick? So here it's closed. Let me use this one so that it's better. Oh, there are two here. When it's closed like this, when it reaches here, the phases now, this was closed, it's closed. When it's closed, it will show you one line. That's why you are able to see here just a line. So when it's like this, it should make a line, means it's closed. The moment they are going to start separating, this one going up and this one going down, this is going towards the septum. So the D, it's the left leaflet is now opening. It's in early diastole. Early diastole, it's starting to open. And as it opens, the second phase will come in now, the rapid filling, or the E wave, or the early filling. Early filling now, it reaches the peak early filling. 75% of blood at this point will move from the left atrium into the left ventricle. At this point, this is the peak. After that, okay, after that, we won't see this F, partial filling, partial deflate closure. So it will now come closer because a lot of blood has now gone into the left ventricle. It's trying to close. Why is it trying to close? Remember, I talked about the PG, the pressure gradients. Blood, the mitral valve is only going to close when the pressure between the left atrium and the left ventricle, there is a difference. As long as it hasn't equalized to a certain threshold, the mitral valve won't close. So the reason why it has partially closed, it's because it has received enough blood. It says, okay, I've received enough blood. Let me close a bit to wait whatever is remaining, if there is anything remaining in the left atrium. And the heart will now say, okay, we have some still small volume of blood that is within the left atrium. And the atrial kick, okay, the atrial kick will now come in. Now, physiologically, the atrium is going to squeeze. Actually, literature has continued to mention that this is squeezing of blood in the left atrium. It is done by the aortic root. This, because of this, do I have this wave? Because of this, okay? You've seen this wave that is coming here, okay? Some literature will tell you it is squeezed. This squeezes, physiologically squeezes, helps to squeeze the blood that is remaining in the left atrium, and it will completely squeeze, which we call the atrial kick. Now, this is the peak velocity. That's why you can relate it now to diastole. This is the peak early phase, peak filling. This is here at this point, there is no flow of blood per se, technically, but it's about to close, but it's saying, no, can you please push in whatever is remaining, and it will squeeze in until you have the atrial kick, and then finally it will close. What is the message here? The message here is that the phases that we see on echo, there are only two, typically the E and the A, because those are the two active contractions, and those are the two phases, the early phase, which is the peak, and the late contractions. Those are the two things that you see. This one, E, the peak opening, and the peak opening, okay, from following the atrial contraction, this one. These are the two that we pick. That's why you are going to notice when we do the EA ratio, the diastolic, when we want to quantify the diastolic dysfunction. What is diastolic dysfunction? This is when we want to see if this left ventricle is able to relax. Now, I'll tell you this. If you've got a condition that is affecting the proper relaxation of the left ventricle, this left ventricle, it will be stiff. You've heard things like restrictive cardiomyopathy, okay? So it will be stiff, this left ventricle to relax, it will be very stiff. As a result, the E, that 75% of blood that should flow into the left ventricle, it won't go here into the left ventricle. Why wouldn't it go there? It's simply because there is no space. It cannot actually stretch. I think that's a better term. It cannot stretch to the expected. And this is common in old age. Very common in old age or in conditions of amyloidosis. What is amyloidosis? Amyloidosis, this is a deposition of fat deposits within the myocardium. How does it affect the myocardium? It affects the myocardium due to the myocytes' poor relaxation. You are going to learn and see how amyloidosis looks like. It will have a speckle appearance. The septum will start having the dots-like around there. And when you see amyloidosis, you are likely to see that there will be restrictive filling of the left ventricle. How will it affect the the diastolic function. It won't stretch. If you've been having myocardial infarction and all those things, they will still affect the compliance of this. So that is how you explain this part. And then this is the posterior mitral valve. And this is what goes on here. Any questions that we can stretch this?
Okay, thank you so much for the good explanation. My other question was, so when we're getting the EPSS, we are only restricted to positioning the scan line on just on the tips of the leaflets of the mitral valve leaflets and is it the septum?
Yes, so
okay.
You are restricted to do that. My question is, where else do you think we can put based on the explanation?
Okay.
Yeah, because the whole idea is to understand, because if we don't attach it to the septum, then you know, science is it's evidence based. So we must explain. If there is anywhere we can put, we can. But for now, this is what is existing, and we can research more where else we can put. But for now, I think this is where we can put. You can read further and then see the sensitivity. And it's just one parameters. Yeah,
I just wanted to get it clear to say maybe you might place it somewhere. Maybe let's say we omit the posterior, or maybe by the virtue of putting or placing that same scan line, maybe you put it obliquely. Then maybe we might end up having a wrong wave instead of having the A wave. Maybe it doesn't really come out well, and now you misdiagnosed, thinking there's no arterial septal to. Yes, that's
okay. No, I get your point. And just to add on what she has just mentioned, when you are picking this view, please optimize this chamber. And by optimization, ensure that your septum, it's in the middle of this pie. This is a pie. Make sure it's in the middle, it's not foreshortened, and then this scan line must be well taken. I've seen a lot of echo, you are measuring the septum, and your angle line, your line is like this. Okay, it's passing like that, or it's passing like this. Okay, sometimes you can have a very difficult echo where you can have this left ventricle is displaced. Okay, displaced apex, very difficult, and you are trying to do this angle is like this. So some machine, they've got a provision written like angle correct. So that angle correct, when you put like this, okay, maybe you are trying to put like this, but the heart still looks foreshortened. So angle correct will help you to correct it until it becomes 90 degrees. If you look at how this was done nicely, okay, and this also is for the tip. If you want to also get the diameter, this is also the best tip to get the diameter, the LV internal diameter. And if you don't put it nicely, you are going to have this elongation of the IVS. You measure from there to there, and then from there, the septum is measured from there up to there. Normal should be 11 millimeters, 6 millimeters to 11 millimeters. That is from here to there. We'll discuss these measurements, don't worry. And then from there, you have to measure up to here as your LV internal diameter. And then the posterior wall, you measure it from there up to there. Don't include the pericardium. So there is a measurement. We'll assess how we measure this. So I think that's all about this one. I hope we've exhausted this one. Coming to Bernoulli's equation, it's in the other presentation. Is it in this one, other presentation? Okay, Mr. Mwamba, you are there.
Yes, I am.
Okay, so the Bernoulli's equation, whatever discussion that can come out, what should be understood, or the message in Bernoulli's equation, is that the speed of blood and the pressure, they are inversely proportional. That one should come out. The question is, when two variables, they're inversely proportional, what does it mean? They simply mean they are opposite to each other. Do we agree or we don't agree, so that we move on the same page?
We agree.
Yes. So they are inversely proportional to each other. So bringing now the issue of stenosis. When blood flow is moving in a tube or in an hollow space, in an horizontal motion, it's moving, and then suddenly there is narrowing of that diameter. We must understand that for this blood to move, one, there is a pressure difference. Okay, basically, let's take it, not even blood, let's take it fluid, in fluid mechanics. Let's take it, fluid is moving in a tube. So you are going to find, for this blood to move, there are forces that are acted upon. One of the forces that is acting on this fluid, it's the walls of that vessel, or whatever container it is. These forces, they are acting on this fluid, and we can comfortably say that this fluid is being compressed and maintained in that vessel. That is one, those forces, they are acting around it. The second force is that for fluid to move from point A to point B, I wish I had that one, from point A to point B, I think it's not, fluid move from point A to point B. I think, let me share it. I think I have it, if you don't mind. Okay, just a minute.
Okay, as you are sharing, maybe just a small contribution from what I read, saying the same. Yes, according to my understanding, what the Bernoulli's principle, what was trying to exhaust was, it's more like it's a deviation of the law of conservation of energy, which says energy is neither destroyed but changed from another form to the other.
Yes.
So, like you said, like in a normal situation, when fluid is coming from a small, let's say a big outlet, maybe a cylinder with a large diameter, then being forced through an orifice with a small diameter, we expect it to have much pressure when it is coming out of the small or from the bigger one where it was introduced.
Yes.
But when you apply this principle, there will be no change in either speed nor pressure. All the other factors like friction or gravitational force are overlooked, and we expect the blood or the fluid passing through a vessel like the heart, when it is passing through from, maybe let's say from the left ventricle to the aortic valves, to have the same pressure and the same speed. That was my understanding. I don't know.
Okay. I think you're able to see my sharing.
Not yet. We are still on the mitral valve.
Okay. Then what am I picking here? Because okay. So when people agreed to say the speed and pressure, they are inversely proportional. I don't know how many agreed. Thank you for the explanation, that one, by the way. But when people agreed that they're inversely proportional, in my understanding of this equation, or what we should pick, is that at that point, at that narrowing point, at that narrowing point, in an ideal situation, I'll still use the word that I used. In an ideal situation, we expect when the diameter is reduced, we expect the pressure of that fluid in that component to increase in an ideal situation. And the speed also to increase because we've reduced that narrowing there, and technically it makes a lot of sense logically. And with our intuition, when this principle applies on a hose pipe, when you press it, speed must increase and the pressure must increase. Do we agree? Normal, ideal. Hello?
Yes.
Yeah, we are trying to stretch a point, but when you apply the Bernoulli's equation, it states that the blood, the fluid, the speed of fluid at that narrowed point, the speed is going to increase. Let me first bring this. The speed is going to increase, but the pressure will be lower, which doesn't make sense when you apply logic there. Mr. Mamba, we are there.
And that's where I got confused anyway.
Yes. No, you are 100% very, very right. When you apply your logical thinking, it doesn't apply. Your logical won't synchronize with this statement because you've reduced the diameter, so everything must increase, speed and pressure must increase. But Bernoulli's equation refuses that principle. Why does it refuse? It's because of the forces that are acting. One of the forces on the walls, the other force is pressure 1, which is pushing blood from where it is coming on the bigger diameter. And then the other force, it's also coming towards it. I wish I could share this, I explain how properly this, but the key issue, I think I'll have a good illustration on this one, but the key issue is that Bernoulli's equation is inversely proportional to the principles of pressure and speed of that fluid on a particular point. That's why it was like, and I read how it was, at points along a horizontal streamline, higher pressure regions have lower speed and lower pressure regions have higher fluid speed. So it's true. It was not making sense, and it doesn't make sense logically. It only makes sense with Bernoulli's principle. So I think I'll find an illustration so that we can discuss it further. We can discuss it further, this one, but there are two forces. I don't know why it's not shared. There are two forces that are acting from the pressure on the other side and the negative pressure on the other side. Okay, just go through on page, not page, on slide 12 in that one. I think where it's written, where there is a negative work and there is a positive work, there is something like that. But the principle is that they are inversely proportional. So we'll try to stress it with other illustrations. And then I've got some other materials. I'll post it just to make it more lighter. I'll try to send something. I'll send something on this one. I promise on this one, I'll stress and send some more materials.
Noted.
Thank you so much. I'll do that. So any questions that we can answer regarding this? Hello?
Maybe since people are still thinking of questions to ask.
Yes.
Even if it's outside probably the topic for discussion, but my request was on recorded sessions like the ones for yesterday, principally, because that one personally I missed. I feel that for us to build properly on what we are learning in future, it's important that you don't skip any lecture. Hence, my request that one can be shared to help me catch up and be at par with the rest.
I think I can assure you it's one of the things that is stressing me, because I've already uploaded up to 90%. So I'm just waiting for a confirmation, because I have to find it on cloud. But otherwise, it's almost, I think by 17, 18, it was almost done. So immediately, once it comes, I'll post it. I know it has delayed, but I don't know what's happening. I'll definitely send it, sir. I know, and I'll be making sure immediately after the lecture we post it. But I don't know why it has delayed. It's just the upload, but it's there on the cloud, but it has to be uploaded. So I'll definitely, I get your point very well.
Thank you.
I'll make sure immediately, even before midnight or whatever, I'll send it over. I'll send it. Okay, we can have other questions.
I have a question, Mr. Mulenga.
Yes.
I just wanted some clarity on it. NICEST limit and raising, just a proper, at least a simple. What can I say?
Okay, I'll be very simple on that one. That's the first question. So NICEST limit and adhesing.
Yes, NICEST limit and adhesing, and its application in color Doppler.
And its application in color Doppler.
Sorry, yeah, its application in echocardiography. Sorry.
Okay, that's the first question. Next question. Next question. Next question, please.
Yes, sir.
Yes.
I have a question on the left ventricular hypertrophy that you mentioned yesterday.
Okay.
I got confused when you mentioned that there was
you got confused with what?
You said it's actually the walls that dilate and not that thicken, sorry, and not the chamber that dilates. Maybe you can clarify further on that one.
Okay, LVH. Okay, thank you. I think yours, it's very simple, so I won't waste time on it. You are not the only one. I think people I've seen people, a lot of people, they confuse when you say hypertrophy, they also related to the let me do this. Do I have this? They also related to the left ventricle dilating or let me use this one. You are able to see this one?
Yes.
Okay, so this is where you check and quantify LVH. The question is, what is LVH? LVH is left ventricle hypertrophy. Now, what quantifies it, or how do you quantify this? You look at this. From here to here, it's a chamber, the left ventricle. This black thing that you are seeing here, it's blood within the left ventricle. We've got this bulge there, it comes down, that is up, it comes down, that is up, it comes down, this continues. This is the septum. We've got here the posterior wall, left ventricular posterior wall, okay, which is this one. It comes like this, down, it goes up, down, it goes up, down, it goes up. Now, the distance from here to there, it's the internal diameter. the question is, why are we calling it the internal diameter? Because this is the chamber itself. You measure the endocardium to endocardium, inner to inner in diastole. Why in diastole? Because the heart has relaxed. And then we measure also the septum, the IVS, from here to there, or from here to there, that from there to there, and the posterior also from that point to that point, we measure it. So when there's been thickening of this septum, we are referring to this septum, which is one of the walls of the mass, the heart, thickening of this or thickening of that. There are a lot of causes, but major one is uncontrolled chronic hypertension, or in sports professionals, this athletics. So when this thickens, for argument's sake, it comes maybe up to here. It has hypertrophied. For argument's sake, it reaches up to here. And then this also maybe thickens up to there, normally. So this, because of the bulkiness of the muscle volume, the muscular volume, or the mass of this muscle, it will reduce the cavity. Do you agree? The person who asked this question, do you agree it will reduce the cavity?
Yes.
It will reduce. So is the left ventricle, are we going to say it has dilated? The answer is no. It has not dilated. In fact, I have something here. I think I have something here. Okay, yeah, I have something here. Look at this. This is end systole. It simply means now the heart at this stage it has completely contracted. Now, when the heart has completely contracted, the muscles are thick. So the distance from here to here, it's not the same distance just by looking the distance from here to there. It's not the same, even the distance from there to there, just by looking. This distance is more short. It's a small distance. This is more longer, okay? So the cavity is reduced. This is not an LVH, but the cavity is reduced. Now imagine if this was already pathological. It simply means the cavity is going to even reduce more, because it will thicken with the already, during systole, it will thicken with the already thickened mass, including in diastole. So it will be very thick. And that is why I was explaining to say, this is the LVOT, this part, it's the LVOT. So when this LVOT has thickened, it will come as much as this side, to an extent where it will obstruct the LVOT, and you are going to be having difficulties for blood to move from the left ventricle to the aorta, via the aorta, because it has hypertrophied. And this is called hypertrophic obstructive cardiomyopathy. It will obstruct this part. Now, what is reducing is the cavity. The cavity is not dilating. However, when this has taken, there is a pathophysiology that goes on here. Now, what will happen now here, when you don't control LVH, get it from me. If you don't control the LVH, there are people who have been with hypertension for a long time, and they don't. These myocardial muscles now, they will become weak. And once they become weak, they will start failing now to pump blood out of the left ventricle. The next thing, there will be congestion within this left ventricle, because the myocardium, this septum and everything, the whole muscle, it is weak, it cannot pump. So because of that, now the blood volume here, they will start dilating the cavity. Now the dilatation now will start. So these which were now thickened at one point, they will be pushed away. So in, excuse me, in LVH, in DCM, sorry, dilated cardiomyopathy, where the cavity has dilated due to the congestion of blood here or other pathologies, the septum is thin. It is very thin. You cannot have a DCM, dilated cardiomyopathy, and the muscles, they are also thick. Then there is something wrong there. So the pathophysiology is that the myocardial cells here, they will be pushed now, they are weak. So I was saying it's not the chamber in LVS that dilates. The cavity actually is just okay, but it's reduced due to the muscle bulkiness. Are we together?
Yes.
Thank you. Anyone who was having problems with, or maybe clarification on this one? We go to the Nyquist limit. The first question that I'm going to, okay, not really a question, but what is a PRF? Because I want us to pick it from somewhere. What is PRF? Pulse repetition frequency. What is it? Anyone who went through it? I think it's people read it. And tell me the importance of PRF. You can go ahead, please.
Okay, well, according to what I read, it was saying it's the number of pulses sent per second. That is it inversely proportional to the pulse repetition period? Which is, to my own understanding, I don't know if it's meaning like the sound that the probe transmits to the reflector.
Okay.
Then the period is that the period that it takes for that for the sound to return, or for the echo to come back from the reflector to the probe. I don't know, but something like that.
Oh, if you don't know, who's going to know?
I need clarification.
Okay, anyone else? You are right. Thank you for that contribution. You are right.
Okay.
Very, very much right. Any contribution to that before we marry it with the Nyquist theory? Anything? We can do it quickly. Anyone who can comment on that? Okay, like she has said, the PRF is basically the number of pulses that are emitted in a second. So your transducer will keep releasing those pulses. So the number of pulses that are released per second, they are very important in ultrasound. Very, very important. Why are they important? They help you. They will help you to analyze an image at a very fast rate. The question is, why is it important, or what is the importance of PRF? When the PRF is high or it is low, what does it mean? So mathematically, we can say when the there is a button called PRF on the button, on the, what's this, on the keyboard there. There is a button called PRF. Now the PRF, having known that this PRF, it's a pulse repetitive frequency, it is very important to marry it with the Nyquist limit and the pulsed wave Doppler. So in a simpler term, I can say the PRF, what it does, it helps the velocities of blood. It helps pulsed wave to measure the velocities of blood at a very normal range according to its range. How do I put it? It has, knowing that the pulsed wave has got limitations in measuring higher velocities. So when you are using the pulsed wave, the pulse repetitive frequency, it has got a limitation to measure high velocities. So if you want to measure high velocities, maybe you want to maximize it, you are trying to see it, you have to increase the number of pulses. You just press it, they've got numbers there, you press it up. Now, when you press it up, you are now allowing this slow pulsed wave Doppler, which is sending and receiving, sending, the signal is being sent and waiting. So you are just trying to enhance its analysis of the pulse that is being sent. And by doing that, you are going to, because remember, PRF, when PRF, the pulsed wave has got, because the pulsed wave has got short time, the pulses are sent in a very short time. They are sent, so that makes the pulse wave not to peak higher velocities. So when you increase, it's more like the PRF will help the pulse wave to measure a certain degree of velocities, not even just low, but it will enhance the pulse repetitive frequency. Now, how do you marry it with this phenomenon of Nyquist limit? Nyquist limit demonstrates, it will help you to demonstrate the wave or the sample gate. Okay, Nyquist limit, the machines have been designed to measure a specific limit of velocity. For example, if the maximum velocity to be measured is maybe 1.5 centimeters per second, I'm just giving an example. So this 1.5, this is the Nyquist limit. This is how much pulsed wave can measure. It can only measure maybe the maximum of 1.5 or 1.7 meters per second. Now, do I have the baseline here? Okay, yeah. So if this is the maximum velocity, remember this is the baseline. This is my baseline here. This is the baseline. Then we've got the positive. And when you look at this, this is 0.3 positive. This is also 0.3. This is it. 1.0, 1.0, 1.3, and it goes on. So from here to there, this is the positive flow. This is the negative flow. So the maximum velocity the positive maximum velocity or positive Doppler shift we can measure, it's around 1.2 maybe from here coming up to here. Now, when you look at this baseline, you can adjust it. You push it down. There's a button called baseline. When you push it down, it can even come up to here. Now, when it comes up to here, what it simply means, you are giving more room to measure the maximum velocity, because this is not the maximum velocity. If this is the maximum velocity for this one, for this valve, no matter how much you are going to use your baseline, this will still be the same. But if you see the velocities are coming up, maybe up to somewhere beyond the maximum velocity here, you try to increase, it's becoming up. So when you use pulsed wave, it's going above. It simply means the pulsed wave has measured the maximum velocity it can. But it will tell you to say, no, there is more velocities here. So the machine now, since it has reached the Nyquist limit where it can measure, it will envelope. It will envelope and it will appear as a negative. For example, if this one measures up to here, if there is anything remaining, maybe a tip like this, you are going to see this tip down here. So you have a line there up, going up. You can't even see the maximum. This is the peak systolic velocity up there, maximum velocity. So you are going to see the other half now coming over, enveloping or wrapping down here. Why is it coming down? Because it has reached its Nyquist limit. Nyquist limit, this is just a theory which states that pulsed wave is able to still communicate. that despite me having picked the maximum velocity, there is still these other velocities which is there, and it's an indicative of a pathology. That's why for pulsed wave Doppler, it simply implies that PRF must be at least twice the Doppler shift. Now, what do they mean? The PRF must be? The PRF is the number of pulses that you are sending. So when you reduce it down, you reduce your baseline, and then you also increase at what rate are you picking the pulse which is coming. So you find that the PRF, this separation, that the frequency will increase because this is time. This is time. So there will be they will be more closer depending on the PRF that you've increased. The whole idea is want to pick as much velocity as you can. So PRF cannot be separated from pulsed wave, and PRF can also not be separated from Nyquist limit because they help pulsed wave to pick higher velocities. And the moment you are going to see an enveloping maximum velocity on the negative part, that is called aliasing. So in short, you are going to say the maximum velocity that can be determined is half the PRF, the maximum velocity. The maximum velocity is this point here. It's that point there. It's that point there. So the maximum velocity that can be determined is half the PRF. And this limit is called the Nyquist limit. So what is the Nyquist limit? The Nyquist limit, this is the term or the phenomenon or the theory that defines that the maximum velocity can only be picked up to a certain level. And beyond that, it goes into aliasing. What is the clinical implication? The clinical implication that it can help you to identify aliasing. What is aliasing? Aliasing occurs if the velocity of blood exceeds the Nyquist limit. Aliasing occurs if the velocity of blood, this velocity of blood exceeds the Nyquist limit. What is the Nyquist limit? This is the maximum velocity that can be determined by the pulsed wave, or the pulsed wave that can be measured by the pulsed wave. And it is determined as the half of the PRF, and this limit is called the Nyquist limit. Aliasing occurs if the velocity of blood flow exceeds the Nyquist limit. So it simply means the ultrasound machine cannot determine the velocity and direction of that particular speed of blood. And the velocities exceeding the Nyquist limit will be presented on the opposite, like I was saying. And by opposite, you can simply also say on the negative flow. So that is all I can emphasize on that. If I'm not bringing it out, then we can have other contributions.
Okay, no, at least gotten something, though my network was tripping.
Okay.
Mr. Mulenga, so are we going to do the septro, Shan, or maybe we do it tomorrow, looking at what we've covered, so that we can go through.
Which one? The septo what?
The other part that wanted us to discuss today, this is the septro.
Oh, the spectrum. The spectrum. Yes. It's up to you. You can tell me. I can also discuss it tomorrow. It's just a short presentation. I can do it tomorrow if you don't mind.
Okay, maybe try and ask others, but for me, I was suggesting maybe we start tomorrow so that you can go through with this that we've exhausted. Then now we start this spectral tomorrow. Maybe others.
Okay, no, that's fine. I think time has also gone. So with those remarks, I bring as much as you can. We can discuss them here together. We can learn together. But my point is to make sure that the theories that are being explained, they are well grasped, and then I'll make sure the recordings that we are doing, they come on time, because they really, like Mr. Mamba said, they build on what is next coming. So we'll end the discussion from there, and then I'll give a lecture. I'll communicate tomorrow. Tomorrow is Tuesday. I'll communicate. It's a very, very short lecture, just to help assimilate. But I have to make sure that before I sleep, I send the recordings so that people can go through them. So generally, how is the feeling of this echo? For those of you with machines, what is going on? Are you able to already see something? Is anything flowing? What is the pace? Is it physiology? Is it working? Okay, so I think we'll end here. If there is no clarification or anything, we can end here. Where you want me to please improve, let's do that. And I think once we do most of the things here, we'll start discussing it on that 4-hour. Your 4-hour will just be discussing and then sending images. The next assignment I'm giving is about drawings. So if you've never done art, you have to start doing art so that we draw the actual images and windows. It will be about windows and labeling, and you post them. That will be the assignment, so that then the next thing we'll be discussing those features and then discuss the rest. So the next assignment, it will be more about drawing the images that we've been talking about. You draw them nicely and label the structures as seen in each window. Very simple assignment. So it's already done. I think I'll be posting it immediately after this. So I end here, and we can call it a night. Thank you so much, and good evening. Sorry.
Thank you.
Mr. Mamba, I'm sure you stopped recording.
I thought when I handed over the rights as a host, you had continued. Okay, let me just check.
Yeah, but it was still recording, I think.
So for me, I can't see where to stop the recording or anything. I think it was still recording, so maybe just check the settings.
Okay.
You should.
No, it was still recording. Let me just check. Okay, so it was recording. Okay.